Hi, you guys, I'm back again. We'll see how well the rest of the lecture period goes for me. Obviously, the more I talk, the more my throat gets kind of upset. So, this part is going to be about genitourinary. One of the things that we want to look at is the difference in physiology and anatomy of children compared to adults. One is that the kidneys are large in relationship to the stomach, and so as a result, they're prone to injury more so than with an adult. So if you think about where the adult kidney is, it has a little more protection and is much smaller in comparison to the stomach. The urethra is shorter, whether you're talking about a male or a female. But if you think about the fact that even in adults, the female urethra is shorter in comparison to a male, so it makes females more prone to urinary tract infections. Well, if you make that urethra even shorter to fit into a infant's body or a small child's body, that shorter urethra makes them at much higher risk of UTIs. What we find is that even little boys have a higher risk of UTIs until they get a little bit older because of that short urethra. Once they get to be about 10, 11, 12 years old, little boys should not be getting urinary tract infections easily unless there's something going on to cause them. And we're not going to go there today. The glomerular filtration rate is slower in infants, and that makes them at higher risk for dehydration. The bladder capacity is only about 30 milliliters in a newborn, which is about an ounce. As you know, though, those little newborns, they don't hang on to that urine. They just kind of pee whenever they're in the mood for it, and that's fine because they wear diapers. By the time a child gets to be about a year old, their bladder capacity is about the size of an adult. The reproductive organs are very immature at birth, and it's not until adolescence that they reach adult maturity. When we're looking at doing a renal system assessment on children, one of the things we want to know is the past maternal medical history. Did the mom have polyhydramnios or oligohydramnios? Were they diabetic? Were they hypertensive? Did they have alcohol or cocaine ingestion? All of those things can affect the urinary tract of the unborn fetus. Then we want to look at the neonatal history. Is there a presence of a single umbilical artery? Is there a presence of an abdominal mass? Is there a chromosomal abnormality or a congenital malformation? All of those things can be related to a renal problem. Usually when we look at the umbilicus after a kid is born, if we only see two vessels, then we start thinking renal with them. Looking at the family history, was there a history of renal disease or uropathy, chronic UTIs, renal stones, or a history of parenteral enuresis, meaning did they wet the bed? That has more to do not so much in the newborn, but would be something that we would want to know if we were seeing a child who had a history of enuresis. Then we want to look at the patient's history. Did they have previous urinary tract infections? Have they had stones? Do they have stasis of the urine? Retention? Have they had pregnancy? So now we're talking about older kids, obviously. Have they had sexually transmitted diseases or any form of bladder cancer? Are they on any medications like antibiotic, anticholinergic, or antispasmodics? And have they ever had any urologic instrumentation? Have they had something done to their bladder? Have they had something done to their urethra that may be affecting their urinary system now? And then urinary hygiene. This is really important because, we talk about the fact that we want to make sure, especially in little girls, that they learn to wipe from the front to the back. And in some cases, we kind of just assume that that's what everybody knows to do. But last summer when I was teaching clinical, there was a little girl that had come in, and she had been coming in for chronic urinary tract infections. She would just get them over and over and over and over again. And the nurse happened to ask the mom about her hygiene practices and discovered that the mom didn't even know that she was supposed to wipe from the front to the back. So she hadn't taught her child to do it either. So no wonder her child was getting urinary tract infections. She was wiping from the back to the front and bringing all of that E. coli and other bacteria from the stool up into her urethral areas. And then we want to look at patterns of elimination. So, do they go first thing when they wake up in the morning? Are they waking up during the night to have to go to the bathroom? What are the patterns? Other things that we want to look for on the physical assessment, we want to palpate the abdomen and percuss. We want to know whether there's burning on urination, changes in the voiding patterns, if the urine is foul smelling, if there's vaginal or urethral discharge, if there's genital pain, irritation, or discomfort, if there's blood in the urine, edema, masses in the groin, the scrotum or abdomen, if there's flank or abdominal pain or cramps, nausea and or vomiting, poor growth and weight gain, fluid or fever, and infectious exposure. Have they been exposed to something that may cause them to have an infection? And if there's been trauma. When we look at the urine, there's certain things that are normal. So we know that there's a color range in urine, that it can be very, very clear, so that it looks almost like water, but it can also be dark if it's more concentrated. It should be clear. It should not be cloudy. In newborns, the production is about 1 to 2 milliliters per kilo per hour. If they have less than that, then we're concerned. In children, the production is about 1 milliliter per kilo per hour. So when we're checking the INOs, we want to make sure that the kids are falling in that range or above that range. When we look at normal urinalysis, this isn't all that different from adults. The pH should be 5 to 9. Specific gravity is usually 1.001 to 1.035. It is not uncommon for newborns to have a specific gravity of 1.001 to 1.005. They don't concentrate their urine well. That just has to do with the immaturity of the kidneys. And so we see that very dilute urine in infants and young children. Protein should be less than 20 milligrams per deciliter. The urobilinogen up to 1 milligrams per deciliter. We shouldn't have any glucose, ketones, hemoglobin, white blood cells, red blood cells, casts, or nitrites in any of the urine. So when we look at urinary and renal disorders, we look at things like UTI, enuresis, and structural disorders like bladder exstrophy. Bladder exstrophy is children that are born with the bladder outside of the abdominal area. Hypospadias or epispadias, you should have learned about that in OB. Obstructive uropathy, hydronephrosis, and vesicoureteral reflux. So we're going to start out talking about vesicoureteral reflux and then UTI and enuresis. Vesicoureteral reflux, or VUR, is an abnormal retrograde flow. So in other words, the urine is flowing towards the kidney instead of away from it, of the bladder urine into the ureter. ureters. So instead of going down the urethra and on out, it's backing up in the ureters and going up into the kidneys. When voiding, the urine is swept back up into the ureters and bladder, where it becomes a reservoir for bacterial growth until the next void. The major reasons for hydronephrosis, which is another thing that we talk about related to this. And it's usually ruled out as part of the workup when somebody has hydronephrosis, which means that there's excess amounts of urine up in the kidneys. The goal of therapy is to prevent pyelonephritis and renal scarring. There's two types of VUR. There's primary reflux, which is a congenital abnormal insertion of the ureters into the bladder. And there's secondary reflux that's a result of an acquired condition. When we look at VUR in relation to nursing management, the big thing we want to do is prevent infection. And it's initially managed medically with low-dose Bactrim. And we give the dose at night, since that's when there is more stasis of the urine in the bladder. So if you think about if you have a child who has been potty trained, they aren't waking up during the night to go to the bathroom. During the day, they're going throughout the day, but at night, that urine kind of sits in the bladder. So that's why we want to give it at night, because then that Bactrim is in the urine that's sitting in the bladder during the night and preventing infection. We do a urine culture every 2 to 3 months, or anytime the child has a fever, because that's the most probable reason for a fever for them. We do a VCUG to assess the status of the kidneys. And the prognosis is that most children will outgrow VUR, but for severe forms, they may have to have surgical interventions needed. As far as managing the reflux, after surgery, we want to provide good post-op care, and that includes having an IV rate at 1.5 times maintenance. And you know how we figure out maintenance, because we talked about that the other night. We want to monitor the urine output via a Foley catheter. We're going to administer analgesics and antispasmodics as ordered. This is a part of the body that likes to go into spasms. And when the ureters go into spasm, or the urethra goes into spasm, it hurts. And when the bladder spasms, it hurts. And so definitely this is one way that we control that so that the pain is minimal for these children. You want to encourage ambulation and advancement of diet to prevent constipation. And then you want to teach the parents how to give the antibiotics. So obviously, until we treat this, it increases the risk of developing urinary tract infections. And that's the next thing we're going to talk about. I'm sure that you guys have had lectures about urinary tract infections in adults. So we'll probably go through this fairly quickly, because there's not a lot of differences between a urinary tract infection in an adult and a urinary tract infection in a child, other than the fact that the child is more prone to get them. It's one of the most common conditions in childhood. About 10% of children have a febrile UTI in the first 2 years of life. The most important host factor is urinary stasis. Uncircumcised males are at a higher risk of developing UTIs. And you can get what's known as an asymptomatic bacteria in the urinary tract. So they may test positive, but they don't show any symptoms of infection. Classifications of UTI is asymptomatic bacteriuria, which is when there's a lot of bacteria in the urine, but there's no clinical symptoms. Symptomatic bacteriuria is when there's bacteriuria with physical signs like dysuria, suprapubic discomfort, hematuria, and fever. An upper tract infection involves the renal parenchyma, the pelvises, and ureters of the kidney. It typically causes fever, chills, and flank pain. The lower tract infection involves the lower urinary tract, and there's usually no systemic manifestations. It's more of that pain over the suprapubic area. So we consider when we're talking about lower tract infection, we're talking about cystitis, or the infection of the bladder, or urethritis, which is an infection of the urethra. Upper tract infection is pyelonephritis, vesicoureteral reflux, and glomerulonephritis are all associated with upper tract infections. Recurrent UTIs is when people just get repeated episodes of them. Persistent is when there's bacteriuria despite having been on antibiotics. Febrile UTIs typically indicates that they have pyelonephritis. And urosepsis is a febrile UTI coexisting with the systemic signs of a bacterial illness, and the urinary pathogens are in the blood. So it's a more serious form. The etiology and pathophys is that the organisms that commonly cause UTI are things like E. coli is the most common in about 80% of the cases, streptococci and staphylococci, and occasionally fungal or parasitic or pathogens. And the anatomical or physical causes we've already talked about, as far as a short urethra in girls and an uncircumcised male. Also, males that are younger also have that shorter urethra, but in comparison to the girls are always shorter for age. The physiologic and mechanical defense mechanisms that maintain sterility of the urine include emptying the bladder, normal antibacterial properties of the urine and the urinary tract, the ureterovesical junction competence, and the peristaltic activity of fluid going down and out. So you can see why the VUR, we don't have that constant heading away from the kidneys, and that's why they're more prone to kidney infections. Alterations in defense mechanisms increase the risk of UTIs. So if you have things that affect your immune system, then you're going to be more prone to UTIs as well. Organisms that are usually introduced via an ascending route from the urethra. Some of the less common routes include bloodstream or lymphatic system. So one time I was talking with one of the residents, and they were talking about how little boys especially have this thing about trying to put things into their penises. And because of that, you see a fair number of urinary tract infections with them when you really shouldn't. It's like, oh, look, there's a hole. Let me put something in it. And so they really mess up the whole protective mechanism of their bodies by trying to poke things in where they don't belong. The other etiology factors is urologic instrumentation, because it allows the bacteria present in the opening of the urethra to enter the urethra or the bladder. So if they've been catheterized, that is one of the things that we're talking about as far as urologic instrumentation. Sexual intercourse promotes a milking of the bacteria from the perineum and the vagina, and this may cause minor urethral trauma. UTIs rarely result from a hematogenous route, meaning from the blood. For kidney infections to occur from a hematogenous transmission, they must have prior injury to the urinary tract, uh, like obstruction of the ureter, damage from stones, or renal scars. When we look at the pediatric manifestations of UTIs, the symptoms will vary some depending on the age, and but some are still similar to adults, like urinary frequency, fever if it involves the kidneys, an odoriferous urine, in other words, it smells, blood or blood-tinged urine. In fact, I think that we see that with kids a lot of times sooner than we see some of the other things. Even with significant bacteria, a pediatric patient may have no symptoms or nonspecific symptoms like fatigue and anorexia. So this may be the mom that brings her kid in and goes, I don't know what's the matter with him, but he's not eating. He just seems tired all the time. He's listless. And that may be the only symptom, and they discover a UTI with them. As far as diagnostic studies, we may do a dipstick. It's quick and it's inexpensive, and it will tell us if there's blood, nitrites, or white blood cells or bacteria in the urine. We can send the urine for microscopic urinalysis. We can do a culture. The clean catch specimen is preferred. And in some cases, we may put a urine bag on a child for collection. The worst thing that I ever have to hear from a doctor is for them to tell me to do a clean catch urine on a little girl that is not potty trained, because you have to do it with a urine bag. And the urine bags just do not stick to little girls very well. And there are some tricks to getting them to stick, and we may talk about that, if I remember it, on Thursday, just so that we can think about some of those kinds of things if you happen to have that situation that you need to get a urine collection from a little girl. Catheterization or suprapubic needle aspiration is another way to get a very sterile collection. It's more accurate. It may be necessary when clean class specimens cannot be obtained. The picture that's over here on the side is what it looks like to get a suprapubic needle aspiration. And literally it's a syringe. It's prepped with betadine or chlorhexidine, and then it goes straight down into the bladder, and you aspirate the urine from the bladder. You actually start to aspirate as you're going down, so that once you hit urine, you stop, and then you get the urine back that way. Sensitivity testing determines susceptibility to the various antibiotics, so we don't want to give a antibiotic that the bacteria is resistant to, so we look for whatever it is that the UTI is susceptible to. We may get imaging studies for suspected obstruction, like an IVP or abdominal CT scan. This is done especially if kids have recurrent UTIs, or if little boys that are 10, 11, 12 are still getting urinary tract infections, because they really ought to be stopping by then. A UTI treatment is by oral or intravenous antibiotics. It depends on how severe the infection is. The appropriate antibiotic is based on the severity of the infection, the urine culture, the urine sensitivity. Often the treatment lasts for 7 to 14 days. Although there's some research out there that says a 2 to 5 day course may be just as effective. So it really depends on how severe the infection is. As far as collaborative care for UTI and antibiotics for uncomplicated cystitis, it's usually a short-term course of antibiotics, although there is a new recommendation for adults that says not to give antibiotics for cystitis, that they can be treated effectively with increased fluids and things like cranberry juice and stuff like that. For uncomplicated UTIs, long-term treatment is trimethoprim sulfamethoxazole, TMP, SMX, or nitrofurantoin, amoxicillin, cephalexin, others like gentamicin or carbenicillin. Pyridium is an over-the-counter medication that helps with the spasms that occur with cystitis, and so those actually work pretty well. There's some combination agents like Uracid that are used to relieve pain, and there's also some preparations with methylene blue tint that's also supposed to help with the spasms. Okay, so we're going to start with the second one. I'm finding that the longer I talk, the more I cough. And just now, I got about halfway through this lecture, went into a coughing spell, forgot how to pause it. And so I'm starting all over now. But this lecture is talking about genitourinary infections or disorders. All right, you guys. So this chapter, or this section, is talking about the genitourinary system and the disorders associated with it. Some of the differences that we see in physiology and anatomy of children that affect the genitourinary system is that the kidneys are large in relationship to the stomach, and that means that they're more prone to injury. So if you think about how small the kidneys are in an adult in comparison to the stomach, with a child, they take up much more space. In addition, the urethra is shorter, which increases the risk for bacteria entering the bladder and causing urinary tract infections. So we know that women as a whole have shorter urethras than males do, and this is no different in children. However, if you think about it in comparison size-wise, a newborn male, their urethra is very short as well. And so we see urinary tract infections in young boys even up to around 8, 9, 10 years old. And then we should see them greatly decreasing as their urethral length increases. The bladder capacity of newborns is about 30 mils or an ounce, and it gradually increases to adult size by the time they're a year old. The glomerular filtration rate is slower in infants, and that puts them at higher risk for dehydration. Finally, as far as reproductive organs are concerned, they're immature at birth and remain so until adolescence, when they mature and they are now able to have children of their own. So the renal system assessment and health history, we're going to look at the past medical history. Did mom have polyhydramnios? If there's polyhydramnios, it usually means that there was some kind of blockage in the GI system that kept the amniotic fluid from being absorbed in the child. So then it built up because they were only getting fluids from the umbilical cord. If they had oligohydramnios, it usually points to some abnormality in the renal system that has kept them from urinating and has decreased the amount of amniotic fluid. If they had diabetes, hypertension, or alcohol or cocaine ingestion, that's also something that we worry about. We look at the neonatal history and the presence of a single umbilical artery. So I'm sure that when you were at deliveries, you noticed people looking at the umbilical cord and counting how many vessels there were in the umbilical cord. If we see that there's only two, it points us towards the idea that there may be a renal problem. It doesn't mean that there is, but it is associated with renal abnormalities. If there's an abdominal mass, it could be a enlarged kidney, like with hydronephrosis. If there's a chromosomal anomaly or a congenital malformation. When we look at the family history, we look to see whether there's been renal disease or uropathology, chronic UTIs, renal calculi, or a history of parental enuresis, meaning that one of the parents had problems with wetting the bed as they got older. This is especially important when we're looking at children that are coming in because they're having problems with bedwetting. Then we look at the patient's history. Is there a previous urinary tract infections? Do they have calculi or stones? Has there been stasis or a history of stasis? Has there been urinary retention? Have they been pregnant or had sexually transmitted infections or bladder cancer? Have they been on medications like antibiotics, anticholinergic, or antispasmodics that may be either treating a urinary infection or may affect the urinary system? Has there been urologic instrumentation? This can be as simple as, did they get a catheter? And what kind of urinary hygiene do they have? Were they taught to wipe from front to back? Last summer, I was teaching clinical, and one of the patients that was admitted had repeated urinary tract infections. In the process of talking with the mom at discharge, the nurse discovered that the mom didn't realize that you were supposed to wipe from front to back. So she had not taught her daughter to wipe from front to back. So it made sense that because she was wiping stool up into her urethral area, that she was developing urinary tract infections. Also, we look at their patterns of elimination. Is this a child that has a history of wetting the bed, but they aren't urinating enough during the day or just before they go to bed? So we have to look at those patterns to see if there's something that could be adjusted there. When we look at the physical assessment, we may do palpitation and percussion, especially over the kidneys and the bladder. The assessment parameters, we're looking for if there's burning on urination, changes in the voiding pattern, foul-smelling urine, vaginal or urethral discharge, genital pain, irritation or discomfort, blood in the urine, edema, masses in the groin, the scrotum, or the abdomen, if there's flank or abdominal pain and cramping, nausea and or vomiting, poor growth, weight gain, fever, infectious exposures, or trauma. So then we have to know what normal urine is like. The color range can be everything from clear, that looks almost like water, to dark amber colored. It may even have blood in it, but that's not normal for it to be. The urine should be clear. In newborns, the production is usually 1 to 2 milliliters per kilo per hour. If they have less than 1 milliliter per kilo per hour, then we're concerned about their urine output and maybe looking at dehydration or other renal problems that may be related to drugs that we've given them for treatment. In children, the production is usually about 1 milliliter per kilo per hour. Normal urinalysis, the pH is from 5 to 9. Specific gravity is 1.001 to 1.035. Infants have a tendency to have very low specific gravity, usually 1.005 to 1.001. And that's because their kidneys are not capable of concentrating their urine until they get a little more mature. Protein should be less than 20. Urobilinogen could be up to 1 milligram per deciliter. On a normal urinalysis, you should not find any glucose, ketones, hemoglobin, white blood cells, red blood cells, casts, or nitrites. Those are indicative of infection. So when we're looking at urinary and renal disorders, we'll look at UTIs, enuresis, or bedwetting, structural disorders like bladder exstrophy. Bladder exstrophy is when a child is born with the bladder on the outside of the body, and it is a very interesting thing to see, but we won't be talking about that today. Hypospadias or epispadias is when the urethra does not exit at the tip of the penis, but on the underside of the shaft of the penis, usually. You should have learned a little bit about that, hopefully, when you were in OB. Obstructive uropathy, hydronephrosis, and vesicoureteral reflux. Hydronephrosis and vesicoureteral reflux are somewhat related to each other because one sort of causes the other. Vesicoureteral reflux, or VUR, is an abnormal retrograde flow, meaning that the urine is flowing towards the kidneys instead of away from them into the bladder. When voiding, the urine is swept back up into the ureters and the bladder, where it becomes a reservoir for bacterial growth until the next void. It is a major reason for hydronephrosis, and it's usually ruled out as part of the workup when looking at hydronephrosis. Hydronephrosis is really when there is an excessive amount of urine that stays in the kidneys and causes the pelvises of the kidneys to be distended. The goal of therapy is to prevent pyelonephritis and renal scarring when it comes to VUR. There's several different types. There's primary reflux, which is the congenital abnormal insertion of the ureters into the bladder. And then there's the secondary reflux, which is a result of an acquired condition. When we look at nursing management, primarily we want to prevent infection. It's initially managed medically with low-dose Bactrim. We give the dose at night because that's when there's more stasis of urine in the bladder. If you think about it, kids are running around all day long and they're urinating all day long, but then at night they don't. And so the urine sits there in the bladder all night, and so it becomes this wonderful medium for bacteria to grow. So if we give them Bactrim in the evening, then the Bactrim levels will be higher in the bladder, and it will help to decrease the risk of infection. Usually these kids have a urine culture every 2 to 3 months or anytime they have a fever, since for them the chance of having a urinary tract infection is very high, especially a pyelonephritis. They do a VCUG to assess the status of the kidneys, make sure that they're functioning okay. And as far as prognosis, most children outgrow VUR, but in some severe forms, surgical intervention may be needed. After they've done surgery, usually the IV rate is running at 1.5 times the maintenance. That means that they're going to be flushing out the bladder and needing to void frequently. So we're going to monitor urine output, and they should have a Foley catheter in at that time. We're going to administer analgesics and antispasmodics as ordered. All of this instrumentation that they had during surgery causes spasms of the bladder and spasms of the urethra and the ureters. And so when we give these antispasmodics, it helps them to have less pain because that spasm causes a great deal of pain. You want to encourage ambulation and advancement of the diet to prevent constipation, and you want to teach the parents how to give antibiotics. UTIs are one of the most common conditions of childhood. About 10% of children have febrile UTIs in the first 2 years of life. And the most important host factor is if there's urinary stasis involved. Uncircumcised males are also at higher risk, and there's this concept of asymptomatic bacteria in the urinary tract. So it's possible for children to actually have bacteria in their urine, but yet not show any signs of a urinary tract infection. So we classify UTIs as asymptomatic bacteriuria, which is when we have a significant amount of bacteria with no clinical symptoms. Symptomatic bacteriuria is when there's bacteria with physical signs like dysuria, suprapubic discomfort, hematuria, and fever. Typically, upper urinary tract infections involves the renal parenchyma, the pelvises of the kidneys, and the ureters. It typically will cause fever, chills, and flank pain. Lower tract infection involves the lower urinary tract, and usually there's no systemic manifestations. So what we call it then is the lower tract infection is usually cystitis or urethritis, and the upper tract infection is pyelonephritis, which is often caused by vesicoureteral reflux, or glomerulonephritis is when we actually have an infection of the glomeruli in the kidney. Other types of things that we type urinary tract infections for is recurrent, which means we have repeated episodes. Persistent means that we still have bacteriuria despite antibiotics. Febrile typically indicates that there's pyelonephritis, and urosepsis is when you have a febrile UTI that also is happening at the same time as a bacterial illness, and you'll see urinary pathogens in the blood. So we have a sepsis that was caused by the urinary tract infection. As far as looking at etiology and pathophys, the organisms that commonly cause UTIs are E. coli. It's the most common in about 80% of the cases. Streptococcus, staphylococcus, and occasionally fungal or parasitic pathogens. Remember, when we start seeing fungal infections in certain parts of the body, we really start looking at diseases that cause lower immunity. Anatomic and physical causes are things like the short urethra in girls and uncircumcised males. Physiologic and mechanical defense mechanisms that maintain sterility of the urine include emptying the bladder. There's a normal antibacterial property of the urine and the urinary tract. Ureterovesical junction competence also keeps the urine sterile and keeps us from having urinary tract infections. And the peristaltic activity, in other words, that moving of urine out of the bladder or out of the kidneys into the bladder and on out of the body is part of what keeps us from getting infections. Alterations in defense mechanisms increase the risk of UTIs. Organisms that are introduced via an ascending route from the urethra is another reason for getting urinary tract infections. And then less common routes are things like bloodstream or lymphatic system. So if somebody is septic, they can have a urinary tract infection that's related to their sepsis. Some of the contributing factors is urologic instrumentation, and that's things like getting a Foley catheter. I'm going to mention this here because it kind of goes along with something later on, but when we start seeing urinary tract infections in little boys, especially as they get older, what we find is these little boys are so stupid. I have no other way of saying it. Because they'll sit there and they see this hole in their penis and they think, oh, let me put something in there. And so in doing that, it's the same as instrumentation, only it's not instrumentation that was supposed to take place. And so we start finding out that these little boys that are having recurrent urinary tract infections are doing stuff like that. And they just usually find out in other ways, but somebody happens to walk in on them when they're doing that, like in the tub or something like that. So it's definitely another reason for kids to get UTIs. Sexual intercourse promotes milking of the bacteria from the perineum and the vagina. And so that it can also cause minor urethral trauma, which increases the risk for UTIs. Kind of goes along with that whole idea of the honeymoon cystitis. UTIs are rarely a result of hematogenesis route, which is by the blood. For kidney infections to occur that way, they must have a prior injury to the urinary tract, like an obstruction of the ureter, damage from stones, or renal scars. So when we look at clinical manifestations of UTIs, they're not all that different from adults, but the symptoms do vary a little bit depending on age. We see urinary frequency. In some cases, if they have pyelonephritis, we may see a fever. They have odoriferous, which is another one of those big words to say their urine smells. They may have blood or blood-tinged urine. And but even with a significant bacterial count in the urine, a pediatric patient may have no symptoms, or they may have nonspecific symptoms like fatigue or anorexia. So what we may see is a parent may come into the pediatrician's office and say, I don't know what's wrong with him. He just seems to be tired all the time, and he just says he doesn't feel good, and he's not eating very well. And this kid eats all the time, usually. And when they do the workup on them and do a UA on them, they discover that they have a urinary tract infection. Some of the diagnostic studies include dipstick urines. They're quick, they're inexpensive, and they give us some basic information without being too invasive. Also, microscopic urinalysis. In other words, we've gotten enough urine that we've sent it to lab. Culture, clean catch specimens are preferred, but sometimes that's not real easy because our kids don't have control of their urinary system well enough. So in some kids, what they'll do is use a urine bag for collection. Um, it's not too bad for boys, but it is a challenge to get a urine bag collection from a little girl. Um, just the physiology of the area makes that difficult, and we can talk about that a little bit on Thursday if you guys want to. We may do a catheterization, so we may do in and out cath to get the urine, or they may do a suprapubic needle aspiration, which is what this picture is. The suprapubic needle aspiration is exactly what it looks like. They take a syringe with a long needle, and after they've prepped the area with either betadine or chlorhexidine, they literally put it down into the suprapubic area. As they're advancing it, they start to pull back so that once they hit the bladder and get urine, they don't put it down further into the abdomen. They withdraw the urine and then just pull the needle back out again. Usually there's very little bleeding associated with it, but usually we'll put a little Band-Aid over that site. It is more accurate. It may be necessary when clean catch specimens can't be obtained, although catheterization is a little less traumatic than the needle aspirations. Sensitivity testing determines the susceptibility to antibiotics, and then we adjust the antibiotics based on that sensitivity testing. In some cases, we may do imaging studies for a suspected obstruction with an IVP or abdominal CT scan. Renal ultrasounds may show hydronephrosis if the child has a structural defect. The VCUG is not usually performed until the child has been treated with antibiotics for at least 48 hours because as infected urine tends to reflux up the ureters anyway, you don't want to have a false positive on it. VCUG is performed once the urine has regained sterility. It may be positive, and it tests for VUR. As far as treatment is concerned, oral or intravenous antibiotics, depending on the severity of the infection. We have to select the appropriate antibiotic based on the severity of the infection, what the culture is growing, and the sensitivities. Often they'll run a 7 to 14 day course of antibiotics, although they have found in evidence-based practice that with certain antibiotics, a 2 to 5 day course may be just as effective. When we look at collaborative cares for UTIs, for uncomplicated cystitis, a short-term course of antibiotics. For complicated UTIs, they do a longer-term treatment with TMP-SMX, which is trimethoprim sulfamethoxazole, or nitrofurantoin, amoxicillin, cephalexin, other medications like gentamicin or carbamazepine. Pyridium is a really interesting medication. It's available over the counter, and it causes the bladder to have less spasms. And so if we're treating for cystitis, that's one way to calm the spasms without giving a true antispasmodic. In that case, if the parent has never experienced what pyridium does, pyridium will turn the urine dark orange, almost red, and uh, and it can stain. And so even a drop of urine in underwear will stain the underwear red or orange permanently. So that's something that they should know about ahead of time before their child takes that. There's some combination agents like Uracid that's used to relieve pain, and also preparations that have methylene blue in them that also work as a combination antibiotic and antispasmodic. As far as collaborative care for UTIs, if somebody has repeated UTIs, they may give prophylactic or suppressive antibiotics. Usually it's the TMP-SMX that's administered every day to prevent the recurrence, or as a single dose before events are likely to cause a UTI. And then we have the bedwetting enuresis. Bedwetting is more common in boys. It usually ceases between the ages of 6 and 8, although it's not completely uncommon for it to last a little longer. And it basically is urinary incontinence beyond the age of toilet training. There can be an actual physical cause for them to do that, or a psychological cause. So you want to assess the family for disruptions or stressors, and find out whether or not there's been a history of the child being difficult to arouse from sleep, because if they sleep really deeply, they may not wake up to know that they need to void. Sometimes you'll hear kids actually talk about the fact that they dreamed that they got up and went to the bathroom, and then they woke up because they were wetting the bed. You also want to look at a family history of enuresis and the child's cognitive status. You cannot expect a child that has a mental deficiency to be able to do the same things that a child with normal mentation are able to do. The diagnosis is usually chronological or developmental, age over 5 years. The bedwetting happens 2 times per week or more for 3 months, and they may have urgency or frequency when they wet the bed. Some of the problems related to it is primary enuresis is onset of wetting in children who have never been dry for extended periods of time. Secondary enuresis is an onset of wetting after an established urinary continence. Monosymptomatic enuresis, which is the most common, is they're dry during the day, but they wet during the night. Polysymptomatic enuresis is daytime urgency. Back to remember, the normal bladder capacity in a child is around 300 to 350 milliliters. Is sufficient to hold a night's amount of urine. A child that's more than 2 years old is expected to have bladder capacity in ounces, so in those larger amounts. So, we can't say that, oh, their bladder is small. It's not any smaller, because what we know is that by the time they're 2, they have bladder capacity like an adult. Some of the psychological factors involved in enuresis is that they may sleep more soundly than other children. There may be emotional factors going on at school or at home that cause them to be unsettled, or there may just be a familial tendency where you start talking to the parents, and maybe dad wet the bed until he was 9, and if you went talking back several generations, you'd find out that grandpa did, so did great-grandpa. This is not an unusual thing in their family. As far as treatment is concerned, we want to encourage the child to drink more during the day and less in the evening. We want to set a schedule for voiding or attempting to void throughout the day. We want to limit bladder irritants like chocolate and caffeine. and you want to limit the intake in the evening before bed. So these kids that go, but I'm thirsty, I want to drink, I'm thirsty. You want to say, no, if you drink, then you're going to want to get up and go to the bathroom, or if you drink, you're going to wet the bed. You want to wake the child to void prior to the parents going to bed. So say the kid went to bed at 8 o'clock and now it's 10 o'clock and the parents are going to bed, or 11 o'clock. Before the parents go off to bed, they go and wake up the kid, take him to the bathroom. You know, it may be one of those things where you have a kid that's half groggy asleep, but you take them to the bathroom and that may help them make it through the night. You want to use bedpans and 2 sets of sheets to decrease the work when an accident happens. So in other words, you put 1 set of sheets down, then you put a pad that doesn't soak through on top of that, then you put another set of sheets on top of that. So if the kid does go to the bathroom, you're only taking off 1 set of sheets before you get down to the next set of sheets. So it doesn't become such a big deal when it happens during the night. At home, you want to have the child wear their own underwear, but when away, pull-ups may help to avoid embarrassment. Let the child know that they are not the only ones with this problem. Other people have this problem. There are these enuresis alarms, so that basically as soon as they start to pee, it alarms and wakes them up. We can also give things like imipramine, which is tofranil, oxybutynin, or desmopressin, DDABP, can help them with that. So we were going to talk about his case study if we'd had this in class. A mother, a 7-year-old, is doing laundry and notices that her son has 3 pairs of pajamas in the hamper. After checking the bed, she realizes that he is wetting the bed at night. How should the mother approach the problem of her 7-year-old's bedwetting? And what aspects of the assessment history are important for the nurse to collect to provide sufficient information for the physician to make a diagnosis? So you should remember when advising parents regarding guidance for their child that they should always consider their developmental stage. So he's 7, so he shouldn't be having difficulty with wetting the bed, although he still falls within a normal range that could be happening. A 7-year-old child is in Erickson's industry versus inferiority stage. So children of this age are moving towards achieving competence. So if they feel that they're inadequate or inferior, they may not feel they are meeting the parental expectations or standards set for them. They should not be compared with other children or siblings, because this is also the time when children learn to be either competitive or cooperative with others. So this is your growth and development stuff when you're considering those things. Consider that this condition may have an organic cause, and therefore a visit to the pediatrician is in order to rule out a urinary tract infection, because that will make you have to go. And then a family history is needed because nocturnal enuresis has strong familial tendencies. Nephrotic syndrome is when the body secretes too much protein in the urine, causing decreased protein in the blood, which causes edema to occur. The liver, sensing that albumin levels are low, increases lipoproteins, causing hyperlipidemia. Most of the cases are caused by damage to the glomerular vessels, and children with nephrotic syndrome are at increased risk of clotting due to decreased intravascular volume. They are also at higher risk of infection, and they're also at risk for acute renal failure if they have steroid-resistant nephrotic syndrome. So you can see here that we have edema, albuminuria, and hyperlipidemia. It is the most common presentation of glomerular injury in children, and the characteristics are massive proteinuria, hypoalbuminemia, and hyperlipidemia and edema. The types of nephrotic syndrome is minimal change nephrotic syndrome. It's the most common of these syndromes, and they don't really know why it happens. It's also known as idiopathic nephrosis, childhood nephrosis, or minimal lesion nephrosis. And it is about 80% of all the nephrotic syndrome cases. Secondary nephrotic syndrome is known, it's when you know or you have a presumed cause. And then they have congenital nephrotic syndrome as well. The pathophysiology of nephrotic syndrome, it occurs predominantly in children between the ages of 2 through 7. It's rare in children younger than 6 months of age or older than 8. And they don't really know what really causes it, but they think that it may be related to metabolic, biochemical, physiochemical, or immune-mediated. And basically, the glomerular membrane normally is impermeable to large proteins, but for some reason it becomes permeable to proteins, especially albumin. And then the albumin is lost in the urine, which gives you the hyperalbuminuria. And the serum albumin is decreased, so you have hypoalbuminemia. And then because of the decreased proteins in the blood, the fluid shifts from the plasma to the interstitial spaces. Remember, fluids always move to where it's most concentrated because they want the concentrations to be equal. So with that, we get hypovolemia and ascites. The diagnosis of MCNS, it's suspected based on clinical manifestations. So the general anemia, the proteinuria is usually 2+ on a dipstick testing. The hypoalbuminemia, hypercholesterolemia, in the absence of hematuria and hypertension, and low serum protein and sodium. It may require a renal biopsy to distinguish it from the other types of the nephrotic syndromes. So as far as management goes, we do supportive care, a diet that's low to moderate in protein, sodium restrictions when large amounts of edema are present. Steroids are the first line of therapy. The dose is usually 2 milligrams per kilo, divided into twice-a-day doses. And prednisone is the drug of choice. It's the least expensive and it's the safest, and that's why they use it. They may use immunosuppressant therapy like cyclophosphamide or cytosine, or diuretics as well if there's a lot of edema. Some of the family issues with MCNS is that it's a chronic condition, which means it can relapse. Making sure that kids are meeting their developmental milestones. There may be some social isolation, lack of energy, immunosuppression because of the steroids that they're on, so they have to be protected from infection. And they get a change in appearance due to the edema that affects their self-image as well as from being on the steroids. Some of the nursing interventions for MCNS. We want to use aseptic technique, especially during any catheterizations. Avoid unnecessary catheterization and early removal of any indwelling catheters. You want to prevent nosocomial infections, so you want to make sure you wash hands before and after contact and wear gloves for care of the urinary system. Also, routine and thorough perineal care for all hospitalized patients. You want to avoid incontinent episodes by answering the call bell and offering the bedpan at frequent intervals. We will also want to ensure adequate fluid intake. Patients with urinary problems may think drinking fluids will be more uncomfortable, but in actuality, It dilutes the urine. It makes the bladder less irritable. It also flushes out bacteria before they can colonize. All of these children should avoid caffeine, alcohol, citrus juices, chocolate, and highly spiced foods because these are irritants to the bladder. As far as discharge to home instructions, they'll have follow-up urine cultures. Recurrent symptoms typically occur 1 to 2 weeks after therapy. We want to encourage adequate fluids even after infection. Low-dose long-term antibiotics to prevent relapses or reinfections, and explain the rationale to enhance compliance. Finally, I think Wilms is the last one that we're going to be talking about today. Wilms tumor is also known as nephroblastoma, and it is a malignant renal and intra-abdominal tumor of childhood. It's 3 times more common in African American children than Caucasian children. The peak age of diagnosis is 3 years of age, and it's more frequent in males. Basically, what we find with tumors in children is that often they are part of embryonic cells that have gone wacko. They aren't doing what they're supposed to do, and so they overgrow. In this case, it's blast cells that have gone crazy. The diagnostic evaluation includes ultrasounds, CTs, and the therapeutic management is surgical removal and chemotherapy or radiation. Some of the things that we have to think about when we're thinking about Wilms tumor is because it is so far down in the abdomen, it's not something that's just easily found. A lot of times families feel really guilty because they feel like if I just would have done this sooner, we would have found it sooner. And Wilms tumors is one of those tumors that we don't find it when it's in stage 1. We find it when it's in stage 3 or 4, where it's already metastasizing because it's just so well hidden in the abdominal cavity. And so we have to reinforce to the parents that there was nothing that they could do to find it sooner, and that we're taking care of things as best we can. Your objectives don't talk about dialysis, but I wanted to talk just a little bit about it because we do have a tendency to do some dialysis with children that is not as commonly done with adults. Namely, we do peritoneal dialysis. Hemodialysis we pretty much do with adults as well. This little guy here is attached to his machine and he's getting his hemodialysis or hemofiltration. So either one will do that, and you can see the tubings with his blood being circulated. Peritoneal dialysis, though, is the preferred method of dialysis for children, and the abdominal cavity acts as a semi-permeable membrane for filtration, and it can be managed at home in many cases. The warmed solution enters the peritoneal cavity by gravity and remains for a time period before it's removed. Often what happens is they'll put the fluid in the evening before the child goes to bed, and it stays in during the night, and then in the morning they'll get the kid up a little bit early and allow the fluid to drain at that point. And you can see here in this picture how there is a catheter that goes into the abdominal cavity, and it's kind of curled around. And so that catheter allows the fluids to go both in, and when it comes time to come out, then it is drained back out again. And it's clamped off in between when you're wanting the dwell time to happen. So that completes this lecture. I hope you guys have a good day. Stay healthy, get plenty of rest, eat good, healthy foods, get plenty to drink, so that hopefully you can avoid getting what I have. And we'll see you on Thursday.